Ripa, you can start.
Good evening, everybody. On behalf of Maharashtra IIP, I welcome each one of you for this second episode of Exciting Casebook Live. And before we begin, I would request our President, Sir, Dr. Ram Gopal, Sir, to please share a few words. Thank you.
Good evening, everyone, and welcome. First of all, I'll welcome today's faculty, Dr. Lakshmi Sobhavat Madam and Dr. Abhijit Chaudhary. Welcome, sir. And today's moderator, Dr. Vinayak Patki, sir.
Thank you.
We have two PG students who would be part of the discussion, Dr. Aisha and Dr. Divya, and their mentor, Dr. Uday Rajput. So I welcome to Dr. Uday Rajput, sir, also.
Thank you.
Friends, this is the second episode of Casebook Live. These are the actual cases which are handled by the moderator, and he would be discussing that actual case. So the diagnosis is not important here. Important is the approach. What is the thought process behind doing each and every step? So welcome, and over to you, Ripa.
Thank you so much, sir. So I would just like to start with this quote by John Holt, that learning is not the product of teaching. Learning is the product of the activity of the learners. And here we have all the learners who are going to actively participate. And as sir mentioned, the experts as well as our budding pediatricians, our PG students are here. And this is going to be moderated by a renowned academician, Dr. Vinay Patki, sir. I would request Pallavi Madam to kindly share the CV slide of sir, please. And we must note that this is a double-blind thing. So neither the experts nor the PG students are aware of the case which, sir is going to present to them today. Pallavi Madam shares the slide. So here we have respected Dr. Vinay Patki sir with us, and we are grateful, that sir is moderating this session for us. Sir is presently the director of neonatal as well as the pediatric intensive care services and ECMO. He's the head of Department of Pediatrics and Neonatology at Usha Kal Abhinav Institute of Medical Sciences. He's from Sangli, Maharashtra. Sir is also the editor-in-chief of Journal of Pediatric Critical Care, even the associate editor of Indian Journal of ECMO, and he has been part of IIP in various capacities. So welcome, sir, and I would now give the dais to you, sir. Vinay Patki, sir, please.
Okay, welcome all the viewers of Case Live, Casebook Live. So first of all, I would like to thank Ram Gopal sir for creating such and Bhavesh and Rajesh for helping to bring out this new concept. First episode we did last month. This time we have different cases, different experts, and different medical colleagues. First, like to introduce Lakshmi Sobhavat Madam. She doesn't need any introduction. But as a formality, I need to introduce her. She is in charge of Wadia Children's Hospital ICU. So many students are fellows.
Madam, please unmute everyone.
Yes, ma'am. Yes, sir. Everyone is mute only.
There is some disturbance coming in between.
Yes, sir. But it's not from anyone.
This Amit Chandra is not.
So, Dr. Lakshmi Madam will be one of the experts today. Then we have another expert, DM Pediatric Critical Care from PGI, Dr. Abhijit Chaudhary. He is working as associate professor at AIIMS Nagpur, one of the prestigious institute, leading academician and written so many articles and be part of so many studies from PGI. Welcome both Lakshmi and Abhijit for this wonderful session. I would like to also a special note and introduction of Dr. Uday Rajput. Though he is an associate professor at BJ, he is our student from Miraz Government Medical College, Miraz, and it's happy to see him mentoring the PG students. So Dr. Rajesh is there, he's our helping, and Dr. Bhavesh Mithya, he's our scientific convener. Without wasting much time, I would like to start sharing the things and we'll start the case. A screen visible?
Yeah.
Yes.
Yes, sir.
Okay. So just few words about how we are going to go about this. This is a Casebook Live. This concept is like Facebook Live. Everything is live. Neither PG students nor experts or mentor know the case. The case, this questions we will first go to the PGs, and they will answer questions according to whatever they feel as of their experience. And after that, we'll go to expert about their opinion, how they would have managed this case. The approach may be different. Diagnosis is already, as Ram Gopal sir has been mentioned initially. Approach is not, this diagnosis may not be necessary, but how you approach such cases, where these are the cases where we stuck, we have a lot of issues, management issues, diagnostic issues, and all that. So this is welcome. This is today's Dr. Divya and Aisha will be the PG students from prestigious BJ Medical College, Pune, with their mentor, Dr. Uday. So let's start with case. So this is a case, 42 days baby. This is one of the twin. This is the second of twin. Was admitted. Just there is some disturbance. Please unmute the other people.
Sir, all the people are muted only.
Okay.
But I think, Aisha ma'am, can you just check your background voice, please?
Okay, anyway. So was admitted in other hospital with cough, cold, and some breathlessness for 2 days, and was referred for having a recurrent episodes of apnea. This was something new. Just to have a back history, this was born 36 weeks. By LSA's birth weight was 2.3 kg, was mild RDS, and neonatal hyperbilirubinemia was there, received NICU care for 8 days. Had actually uneventful recovery through NICUs, was all right for next 4 weeks, has received BCG, OPV, and HBV. He was exclusively on breastfeed, and admission weight was 2.5 kg. So when baby was brought to us, baby was afebrile, was tachypneic, respiratory rate was 62 to 66 per minute. Intercostal and subcostal recession was there. SpO2 on room air was between 86 to 88%. Baby was tachycardic, heart rate was 170, no pallor was there. Chest was, your air entry was equal on both sides, bilateral fine crepes were there, and scattered rhonchi were there. Heart sounds were normal, no murmur was appreciable. Abdomen was soft, there was no organomegaly. CNS interfrontal was at level, but was pulsatile. Baby was crying, but getting intermittent dullness. So now we did the investigation. Hope this X-ray is visible to you. This is X-ray, and which shows bilateral infiltrates, reticular infiltrates with air bronchogram on right side. Because baby was crying, there's some gaseous distension is seen in the boil loops. pH was 7.395, PCO2 was slightly on higher side, 44.9, PO2 was 61. This was VBG. PF ratio was okay, 200. Sodium, potassium, chloride, calcium, ionic calcium, and glucose were normal. So this is the background of history, clinical examination, and basic investigation at ER. So what are these problems are? This is a NICU graduate. This is acute respiratory infection, hypoxemia, and recurrent apnea. So I will first go to the PG students, how they will approach this case. So what things will go in their mind, and then we'll take opinion of experts. PGs.
Thank you, sir. So for in this scenario, as the baby had respiratory distress with a poor activity, with not maintaining saturation on room air without oxygen, my first step would have been seeing the airway and the breathing. So I would have first secured the airway and would have done an intubation and taken on mechanical ventilation. Then I would have seen the circulatory part, circulation.
With this, you go for intubation directly.
Yeah, bubble
CPAP or HFNC will record. Sir, actually, the respiratory rate is high, and there is tachycardia, tachypnea is there, intercostal retractions are there, subcostal retractions are there. So mostly it will be lung pathology. First, we will go for HFNC, because already baby is on OFO to 88%, na sir.
Yes.
Go back to the slide which shows the clinical
Yes.
status. Yeah, thank you.
First, we will go for normal or O2 bubble CPAP, or if it is not maintaining, we will go for her HFNC. As the baby is on an ICU graduate, and it is so much of tachycardia and tachypnea with the SpO2 of 86 to 88%, we will take the baby on HFNC, and we'll go for the circulation part. But everything is normal as you told. So and the disability part also, CNS wise baby is normal, and there is no exposure as per the this one. And after this we will go for what
So
causes
what do you
this
think about
pneumonia.
there are two problems are here. One is respiratory infection, as you already said, with some hypoxemia, and other is recurrent apnea. So
Recurrent apnea.
how will you approach this apnea?
This apnea could
In that assessment, I want to add that the CNS is not normal for the baby. Please go back. Yeah. Baby is dull. Okay, so that is what it is saying. The baby is dull.
dull, poor activity is there.
Correct. So child is, if you look at the ABC kind of approach here, your baby is okay, maybe maintaining airway because there is a cry. The child is having significant respiratory distress with hypoxia, which is apparent on your SpO2. This is without oxygen. There is significant tachycardia also. Okay. So there is some cardiorespiratory plus that is affecting your CNS at this point. So assessment wise, I would say this child is in cardiorespiratory involvement with a primarily maybe a respiratory infection, which is causing this child to have these issues. Now, whether this apnea, now the question is, what do you want to do with the CNS? Is it respiratory failure? Will you qualify it as respiratory failure here, Aisha?
CNS is not that much depressed. Tell.
No, ma'am, not yet.
Huh.
The BBG says the PO2 is still 61%. 61%. And
And
I
the
would
pH
like
is
I would like you to comment on using the ABG as your definition for respiratory failure.
it is
Do you
not in failure, ma'am. PCO2 is still 44 only.
No,
And the
but
pH
why would you want to use the ABG only? Is the ABG the only reason to classify?
no, ma'am. The baby is dull, but the cardiac part is normal, but the CNS part wise,
because the baby still has, like, the cry is still present, and he has not developed like failure like symptoms like bradypnea or a very poor dull
there is no
activity.
so much of poor sensorium is not there.
Okay.
Are you
Okay.
saying
We'll
okay, you want to move ahead?
yes.
Desaturation
Abhijit,
is
any comment from you?
I want to say that respiratory failure has to get acknowledged here.
Yes.
And
Yes.
desaturation is respiratory failure to some extent. So
Yes.
how, whether it with oxygen, not oxygen, you have to look at response, but you have to be aware that you're dealing with a child who's more sick than what you think you are dealing with.
Yes.
Just
Correct. Abhijit, just quick comment from you and then we'll move further.
Just a two-liner comment.
Yes.
It's very important to know, you are very correct in doing the ABC. In the breathing part, we get a lot of information in this child that there is a lower respiratory tract involvement, probably airway and alveolar involvement. And considering the history, probably I am dealing with most likely bronchiolitis. And whatever the respiratory parameters are there, 85, 86% saturation, ABG 40, in considering my possibility, 45 CO2 is good enough. I would be happy to have HFNC at my hand, would like to give one nip and start the child on oxygen
Okay.
and would like to evaluate further.
Okay.
But
So
one comment on recurrent apnea. Now,
yes.
this my statement was very good till the child was having only respiratory complaints. Now, when a child of bronchiolitis have recurrent apnea, there is certain etiology, and we have to be ready with our intubation. But it's a very important thing.
Then we started child with monosafe amikacin because this is viral etiology was suspected as HFNC was started as you with FiO2 of 30 and flow of 5 liter, but child was only 2.3 kg almost. Nebulization was started. Day 2, he had apnea episode increased. Now child started becoming desaturating. SpO2 up to now 60s, but there was no episodes of bradycardia with this. Again, biochemistry was repeated, was normal. Total count was slightly lower side, 4,500. Platelets were 4 lakh. CRP was 14. Procal here is negative. Now, question is, are you going to ventilate?
Yes, we will intubate the
What is
baby.
just listen. Just what are the additional treatment you want to do, and what do any further investigation you want to do? Yes.
So we would intubate the baby at this stage. Then second, for further investigations, as in
First, talk about
in the
ventilation. Ventilation. What strategy of ventilation you will use?
Mechanical
intubation, mechanical ventilation on a PSIMV board.
Okay.
Then we can furthermore for the investigation part, sir. Like
What drugs you will use for rapid sequence intubation for this child? Child is having respiratory involvement. Child is having some CNS involvement is there. Child is having tachycardia, hypoxemia. So how will you go for your rapid sequence intubation? Anything else you want to do? Any comment about any specific precaution you want to take about intubation in this child? What can go wrong if you do start putting this child suddenly intubate this child?
Bronchospasm, they will go.
Okay. Okay. Okay, then we'll just take just you quick comments from both of you about what further investigation, and then our expert will tell you how to ventilate and intubate this kind of child. Just what additional things you want from this child?
An entire septic screen would be required, as in the CSF was not done earlier. So
okay. Anything else? Any point of care investigation, handy investigation, bedside?
Pneumothorax. If we having echo, we will go for the echo because of the recurrent apnea is coming. We have to rule out the cardiac causes also.
Anything related to for brain? Anything you want to do?
USG AF will do.
Okay, now we'll shift our. We'll get just this is the child now. Lakshmi ma'am, how will you go about this child? What further? How will you go about ventilation, intubation, and what are the precautions?
So basically, this baby is having repeated apneas, significant desaturation. So the child deserves to have invasive ventilation. Okay, so we will have to use rapid sequence. Maybe this baby may, I don't know, hemodynamics was probably all right, is what I am assuming. Yeah.
Yes.
So we could use something short acting like midazolam. I think everybody has access to midazolam and fentanyl in their units. So maybe midazolam, fentanyl would be my drug of choice at this point. There is no contraindication to either of them that I see just now. There is significant hypoxia, so I would like to, ensure that my oxygenation is better before. I mean, I would do a proper oxygenation, pre-oxygenation in this patient before I go ahead and do the intubation. I don't know if we can, but if possible, we can put him on an NIV by a nasal mask and use that as a method for pre-oxygenation also. That is what I was thinking in
Okay,
this.
Abhijit, any views on this? And just add your expert about any investigation bedside you want to do for this child.
No, sir, regarding the ventilation, agree with all. Mechanical ventilation, because it is recurrent apnea with hypoxemia. So the mechanical ventilation is the choice. Ensure NG tube. Ensure you give a good slow bag and mask ventilation followed by rapid sequence intubation. Regarding the further investigation, sir, since there is a recurrent apnea, I would still like to have basic investigations that my sodium has not dropped further. How is my ionized calcium and what is my sugar? And in further investigations, I would like to see whether CNS is also involved. So I will plan LP,
Yes.
neurosonogram, and
Yes.
a respiratory panel PCR.
Okay,
Yeah.
thank you. Good. So
The
this
minute
this
you
is
intubate, if you can get in your respiratory panel, it is a good idea because you'll get a fresh sample, and
yes,
afterward, the later you do it, the more colonized
more
samples you
chances of yes biofilm and contaminations are there. Exactly. So we intubated with whatever things have been expert as per the expert comments are there. We put on PCSC mode with minimum settings, and we did bedside cranial USG. This was showing lateral ventricles were dilated, having periventricular leukomalacia of grade 3 on right side, and some query hemorrhage or leukomalacia on left side. We started with some additional of because it has maybe had convulsive apnea. We put on levetiracetam, fentanyl was given, and aminophylline was started because a lot of spasm, and BB was started on feeds 5cc3 hourly, and we have sent the respiratory panel also. So day 3 now ventilator support same, tachypnea was there, and now here again PB has started episodes of desaturation, almost 3 to 4 episodes with same settings of ventilator, and here now liver size has started increasing. So Peaches, what is your take now?
What?
CRT started prolonging and different few episodes of desaturation, and liver size started increasing. So how will you go about it?
Sir, actually CRT is prolonging. We'll go for inotropes by this time. Because of this, all the things, it could be septic shock, or in this liver size increase with this recurrent apnea. It's because of the mostly sepsis. As and in the so we'll go for noradrenaline and with dopamine. Sorry,
Just bottom
dobutamine.
CRT just 2 to 3 seconds, not that delayed. Not too much delay. Okay, we'll go to experts then. First we'll go to Lakshmi ma'am and then we'll go to Abhishek.
Okay, so now there is a child who's ventilated. His tube position is all right. Your ventilator is working well. Your your dope has been ruled out because that would be the first thing on any patient who's having a desaturation on ventilator. If you've ruled out dope, then the problems could be per se. First could be that the lung itself is worsening. Okay, so you need to look at whether the lung is worsening. You may need an X-ray further to see what is happening. You're saying same settings of ventilator, so I'm thinking that the peak pressures and your maps are not increasing, so maybe the lung is not worse, is what you're trying to say. Now you're also saying that the liver size is increasing. Now, why is the liver increasing in a patient who has, who came with you with a respiratory infection? So whether there is a cardiac involvement which is there, so whether there is a myocarditis in the patient who, because we are suspecting viral, from what I think, we are thinking viral. If we are thinking viral, then that. The other thing I wanted to know was what is the, whether this could be pertussis. 40 days is a decent time to have pertussis-like infection, where whether the mother was vaccinated for pertussis. Those kind of information I need. So if you have spasms, in pertussis, you have such bad spasms that even on venti, even with pressures, you can see a red choking patient even on a ventilator. So whether those are those episodes, but in that the liver would not increase. So that is what I'm thinking.
Okay, any take, Abhijit, anything extra or different way of your thinking?
Extra. So we are dealing with a child who are suspecting that he is a bronchiolitis, and we know pneumonia per se can be a disease where SIDH fluid retention is a problem. And so I would be interested in knowing what is my intake and output, and am I fluid overloading, considering the fact, and obviously heart may be involved and dope has been ruled out. So
Yes.
I would be also paying particular attention to the intake and output.
Okay. There was no fluid overload. Fluid balance was good. There was CRT was borderline 2 to 3 seconds.
Okay.
Dope has been ruled out already.
Okay.
And this is the echo, which shows is RV dilated. It's what moderate TR was there. Moderate pulmonary hypertension was there. This was a diastolic dysfunction. LV was okay, and there was no pericardial effusion. IVC was collapsible. So in view of this, as experts are thinking, we have started like some kind of a myocardial dysfunction was there, and we started with dobutamine drip and Lasix was started. So this was on day 3. As then day 6, from day 3 to day 6, so this is slowly started improving. There was no saturation. Patient was shifted to SIMB mode. Tachypnea reduced. ABG showed now PCO2 was 74, PCO2 40. Lactate is 1.2. As you are expecting, like we have ruled again, we do it sodium, potassium. They are fairly okay. Like feeds, we started 10 cc 3-hourly baby DT feeds. So things we thought we are sailed the crisis and things were going in a proper direction. And as madam was asked to say, that means the respiratory panel report has came now, and it has came early. I am showing here. This was RSV pneumonia. So basically, it was proven respiratory syncytial virus pneumonia was there. So this is the problems are here. RSV pneumonia, some myocardial dysfunction is there. Convulsive apnea was there. Desaturation is there. So what next? How we are going to do a further any other investigations you want to do? So this was on next day we did. So as we said, the other systems, whether they are involved. So we did RFT was okay. LFT is also okay. And we did, as you suggested, all about CSF. So because of convulsive apnea, we did CSF. But surprisingly, it was processed very fast. Within 10 minutes, we could able to get the result. Proteins were 36, glucose was 55, RBC were absent, and only there were 2 cells, all were lymphocyte. Simultaneously, sugar was 82. So that was not much issues were there. Potassium and other things were there. Ionic calcium was also here, normal. So this was on day 7. So day 7, this early morning round, we did this X-ray, and this X-rays was something. We'll see from students how they get this. So baby was here on PCSC mode, PIP over 18/5. Baby was quite comfortable. We given trial of extubation here, put on pressure support mode, was quite okay. But baby has developed right middle zone dizziness. So now PG student, what is this? Are you going to extubate this child? Any other investigation you want to do in this child? And any change in the management you want to go for? Yes. Now you know this is RSV pneumonia, day 7. We have ventilated this for more than 48 hours. Yes, unmute yourself. PG students, unmute yourself. Yes.
Sir, as the ventilatory support is on almost minimal, and the SpO2 is maintainable, and baby is comfortable, so some amount of middle lobe haziness is still present, but we can give pre-DEXA before extubation, and of course we will extubate the child to HFNC, and for further we can try actually Tamiflu already started, so we can continue the steroids, HFNC with nebulization with steroids, and either management.
We'll go to experts. So both of you, Lakshmi and Abhijit, what will be your take on this day? We are going for rounds. This is the X-ray.
So
baby is fine. Are you going to extubate this child, or you will wait?
Okay. So extubation, predominantly, if we see the ventilatory settings, they are okay. but there is in chest X-ray there is a new haziness basically, and we know that patchy atelectasis can occur in these patients new onset. Very important, I would like to see whether there are fever, whether there are increased tracheal secretions, whether there are increased my inflammatory markers. And important thing is that I won't chase the radiological infiltrates, but if I extubate this child, if everything is conducive and my extubation checklist is fulfilled, I would like to extubate this child on HFNC because already this child has myocardial dysfunction. I won't like to just take out that the afterload effect of mechanical ventilation by extubating on nasal prong oxygen. So I would be careful.
Okay, so
I
this
would
child
have
has was
preferred
no. Yes, Lakshmi.
NIV for some time at least, because I don't know whether this patch is really going to change my patient's, transition. So maybe I would be more conservative and say I'll put him on NIV and watch him on NIV and then take a chance on then de-escalating further if that
Okay.
that is an available choice for me. So I will
Okay.
do that.
Okay, there was no fever. Baby was comfortable. There was no secretion, excessive secretions were. Then, as you know, there was no increased requirement. So we did as for all you are saying, we went with same thing. But we extubated this baby. We switched to piperacillin tazobactam because of some new patches there, and simultaneously we sent both cultures, tracheal aspirate as well as maybe as we are all agreed, we were going on same page. 5 liters HFNC was maintaining. Baby was feeds were 15 cc 3 hourly. Baby was tolerating. Day 9, slowly chest signs better, tachypnea reduced. We went to HFNC reduced. We went up to 20-25 cc. Day 9, baby was shifted to nasal prongs. Baby was started spoons also. Here now the things are started problematic. Platelets have started now rising. 7,69,000. CRP 32. 11 WBCs was 11,900. So, and this is the report from blood culture, which has grown MDR Klebsiella, which was sensitive to tigecycline, which was sensitive to phosphomycin and doxycycline. Rest, it was cholestyne, meropenem, it was resistant. Simultaneously, another new thing has come to us, which has created more confusion now. So we sent tracheal aspirate, which has grown Stenotrophomonas maltophilia, which was sensitive to minocycline, chloramphenicol, ceftazidime tazobactam, and tarticacillin clavulinate. So here is a now what we are now having a different organisms from 2 different samples. Selecting antibiotic is the issue now, and there is slightly increasing in the CRP levels. Platelets are also increasing. How will you go? PGs first, then we'll go to experts.
Can you go back to that blood wala so that
Yes.
we can see? Yeah, thanks.
Yes. This was blood. This is tracheal aspirate.
Aisha, unmute yourself.
Aisha, unmute.
Yes,
Unmute.
sir.
So now what we are just, I will just summarize what things had happened till now. A community acquired pneumonia child who has been diagnosed as RSV from initial things. We have ventilated in between, some episodes of myocarditis is there. We extubated this child. Though there was a right middle zone pneumonia, few things went slightly better for 2-3 days. Now again, child started deteriorating in terms of labs only. And here we are getting 2 different samples from 2 different organisms. How will you choose? He is currently on piperacillin tazobactam. Yes.
We continue Piptas and we'll add.
Sir,
TGC.
as we have already added Piptas and there is sensitivity to Piptas, we can continue that antibiotic. Like we would continue. And
For blood,
This is piperacillin tazobactam is resistant here.
no,
the other one is
the tracheal aspirate, sir.
Okay.
The other
Okay.
one. It shows sensitivity to tazobactam, so we can continue that.
Okay.
And
We will add
But
other
how do you approach any culture report?
how much sensitivity pattern the highest this one will give available.
Okay,
the
before that, what do you see?
Both are same drugs or not, we will check. Same group of
Same
drugs,
group
matlab
of
we won't
drugs.
add again
Okay.
same
If the
group drugs.
mechanism of action is the same, then there's no need to add another drug of the same group.
Any role of colony count or is there? From where the sample has come, does it have any value?
Maybe.
Okay, we'll go to experts.
Contamination.
First, we'll go to Abhijit, then we'll come to Lakshmi.
Yeah. So this child was on Piptas, sir. Was this child on central line? He had a central line.
No, though there was no central line, he was on peripheral line.
Okay. But still, there is no doubt that this is a blood infection hospital acquired for Klebsiella. I would like to give tigecycline. That is, I'm clear. Regarding the tracheal aspirates, now there is two issues. Whether he had a ventilator associated pneumonia or he had just ventilator, this colonizer. What history which has got till now is this: there is increase in the inflammatory parameters along with probably fever. Is there a respiratory worsening?
No, there was no respiratory worsening.
Okay, so here I am plus minus. Probably I won't chase this report of Stenotrophomonas maltophilia because to call it VAP, this child fulfills the criteria that he was ventilated for more than 48 hours. Radiologically, there were new findings, but it could be patchy atelectasis. But if there is no respiratory worsening, I would wait. And the colony count is also 10 to the power of 4. So for that, I'm not very sure. I would treat Klebsiella, and this is my take, sir.
Okay, Lakshmi.
Yeah, so I'm okay with what Abhijit is saying, but my question is, when was this blood culture sent? How was this blood culture sent?
Yes.
So those are also questions which we need to answer because many times most of the time I'm actually thinking, why did we send this culture? Do I
Yes.
have to act on this culture is my
Yes.
first question.
Exactly. I will answer
So,
that question.
yeah,
So
if my baby has a high CRP,
Yes.
I mean, I'm assuming there was something which initiated. Was there hypothermia or something?
Yes.
Because
So
the baby is small.
frequent episodes of apnea, that
Okay.
a new patch on X-ray. So that
Okay.
we did.
So for that, it was done.
For that, we
Yeah.
sent both samples from
Yeah.
tracheal aspirate as well as blood culture, and
Okay.
other things were the blood counts.
In the
So-
sensitivity, we had tigecycline, fosfomycin, and what else?
Let me just have this.
TG, phosphodoxy. Neither, I mean, it's like nothing is really good. Fosfomycin is not even a question of drug of choice for this organism unless it is in the urinary tract. So this is not a urinary infection. I'm not going to use fosfomycin. Doxy comes with its own set of problems in that young age, may not really help. Then I'm left with tigecycline, which
For viewers,
will
questions
use.
will take later. Will
I
not
will use,
disturb the.
but the thing is, it is not very good for bloodstream infection. It does not stay in the bloodstream that much.
So
we
microbiologists were very much apprehensive, and they said, "Sir, this is Stenotrophomonas maltophilia. How you are sitting so coolly? Do something." So, what will you do? Is it okay only with adding minocycline is okay? Sorry, tigecycline is okay.
Yeah, I think
ठीक
the
है,
lung
CLD
was not worse. The lung was
Okay.
not worse. So
Okay.
it was okay to wait on the lung.
Okay, so
And,
this is our.
one comment. Can
Yes.
we just ask them to check this Stenotrophomonas sensitivity against tigecycline?
Yeah.
Yes, we'll see that later part. See, for viewers, we will answer all these questions from the expert at the end of the sessions once we come out of the diagnosis. So those who are raising. So now here problems. So what we did, maybe maintaining vitals, soft O2, full spin, only tigecycline we had as per, we were not given much importance to the Stenotrophomonas because colony count was here to 10 days to 4 only. But day 12, the problem has again happened. One episode of convulsion has occurred. It was with tonic posturing. Heart rate was that time 238. Saturation was 80. We will just put on 1 to 2 liters O2. We are loaded with phenobarb and Levipil. This is the ABG, which is now we are come to day 12 of a, with this background of so many different antibiotics, primary etiology with normal cranial, almost some ventricular dilatation cranial issue was there. So lactate here was okay. Phosphorus, we said, are we missing again something metabolic? So we did calcium phosphorus alkaline phosphatase, ionic calcium was okay, magnesium was okay. Nothing we could find. Sodium potassium chloride were okay. So now here MDR Klebs sepsis under treatment, new episode of seizure. What next? PG is first. Yes, unmute yourself.
Sir, just one question. At the heart rate of 230, like, was there an ECG taken?
So it is. This was in with during seizure. Na?
During seizure.
Okay. Sir, it could be a hypoxic seizures or any already they were mentioned and ventricles are dilated. So
that was mild dilatation, which was seen on the CSF we did. CSF was okay. Now child is getting on day 2 again seizure convulsions, like same thing what we had initially on day 1.
It could be first one is hypoxic seizures because of the patch which is coming new, or second one is the baby could have some CNS manifestation like some abnormalities. So we will repeat the USG, AF, and if possible, we can do the CT brain or an EEG for this child. What could be the cause of the seizures?
Okay. Lakshmi madam, your expert opinion on this.
Definitely seizures, if you see, I agree with their thought that they want imaging, whether we can do MRI versus whether we should do another MRI followed by a CSF, I guess. So that because there is recent onset bloodstream infection, so and you had high CRP and everything. So whether that this has gone into the brain is something I want to see.
Your preference? CT versus
MRI followed by yes, by the CSF, because most of the time our radiologists get very angry if we do the CSF before we do the MRI, because they find some changes. I don't know what changes they find, but they're very unhappy.
Abhijit, your take.
Yes, sir. MRI better than CT and CSF.
So this was MRI. This was plain axial view, which shows ventricular dilatation, which looks benign. Subarachnoid spaces were quite prominent. This was another view. I will go for next thing. This was T1. This is FS plane. This was on T2 axial, and this was the report. Sulcal flare sulcal hyperintensity showing post-contrast enhancement involving bilateral cerebral hemisphere, suggestive of meningitis. And there was hyperintense T1 showing blooming of SW1. So which likely they say ki focal intraparenchymal hemorrhage. They were very sure about there was no subdural effusion or empyema. And they said it is a benign enlargement of subarachnoid space in infancy. CSF was normal. Again, same thing was there. Now, this CSF culture has grown something else, which has grown
This is the
Spingomonas.
first CSF culture, or the
No,
you
this
did
is
the
second CSF.
You did a second, which was normal.
Yes.
Oh, okay.
And this was the CSF has shown Spingomonas possivolvis, different organisms, different sensitivity. Now PGs, how will you take this?
Session is good. Or meropenem also they are given. So if you pencil kitna hai? More than less than 0.12. Gram negative.
So
There
for
are
this, in
multiple.
this case,
Yes. Go ahead.
So for in view of this report, we can go ahead with adding cefepime or
Cefaperazone, sulbactam, we can
cefepime or
use
cefoperazone
cefaperazone,
that
sulbactam,
can
we can
has a good CNS penetration, so it can help controlling the infection. And tetracycline.
recycling code.
Okay, we'll go to experts. Lakshmi first, then Abhijit.
We'll add cefep-
Okay, so you have MRI which says meningitis, and you have a CSF which, though you're saying does not show any pleocytosis, but the culture has grown Sphingomonas, which is a gram-negative organism. It is something like Pseudomonas kai variety mein hai. So now, and the patient is symptomatic in the form of having seizure. So you may want to treat this. My thoughts are whether I want to add meropenem would have been the easiest answer here because it is a more broad spectrum antibiotic to use. And was my Klebsiella resistant to meropenem?
Yes.
It was, right? Yeah.
Yes.
Okay. So then we go ahead and continue the TG and we add meropenem here, I think.
Abhijit?
Yeah, probably the same thing, sir.
Mm.
Continue.
Will you give importance to this
Yes,
CSF report?
yes, because clinically the child has worsened and the CSF culture has grown. And obviously, if we have taken the sample properly and processed in a proper way, this was a bacterial culture of CSF or like a
Yes,
CT scan?
yes, bacterial.
And we trust the lab also, right? Because
Yeah.
we're having too many positives.
Yes.
So
Yes.
definitely we'll treat this culture, sir.
Okay, so we'll consider here, and as per expert, we went ahead with adding meropenem. Sensorium was dull, baby was taking feeds. Now, in spite of adding meropenem, total count started rising, platelets started dropping, CRP started increasing, and this is the X-ray. We are given some mannitol because of, though it was not showing any raised ICP or anything, just 1 or 2 doses just we have given. Now let's see what are the problems. So MRI shows Sphingomonas possibilis meningitis, which is under treatment. As per experts' opinion, it is on meropenem. Blood culture MDR Klebsiella, which has come much earlier, again under sensitive drugs. Tracheal aspirate, Stenotrophomonas martophilia, which we have not given much importance, we consider it as a biofilm. But now deteriorating sensorium is there and rising inflammatory markers. So how we should go? First PGs. Yes, unmute yourself. So here,
So
what
in-
questions? Yeah, what questions you will ask to yourself? Are we going on clear lines, or you want to rethink something? Want to revisit the reports, revisit the diagnosis,
So
or your choices
since
of
we have
antibiotic? Yes.
we have added the antibiotics as per the sensitivity, but still there is no response to, and the sepsis is still ongoing, as the markers are also showing us. So a repeat septic screen is what we would go ahead with.
Already I
And
showed.
repeat-
I showed this is the repeat septic screen on day 14.
the cultures.
And well, after adding marrow also it is increasing. So we'll recheck once that sensitivity pattern of all the drugs we got.
I will show.
And the X-ray is showing some bowel is like
I'm showing the CSF culture now. Any pick up from this basket? Anything you want to pick up extra?
Levoflox, meropenem, minocycline.
You already said about cefoperazone, sulbactam, and cefepime. Though expert has given different opinion, So anything you want to do, or is there any thought process different in your mind?
Sir, actually, we will change the antibiotic
Okay.
and we can add both in combination also. And that X-ray is showing some bowel gastроid is not good. Can you please? This large bowel is something different. Any ongoing neck is going on.
So how will you go now? Till day 6, day 7, what was happening? Baby was okay. Investigations were different. Now baby is also deteriorating.
Sir, I want to check that abdominal X-ray is somewhat showing the gaseous distension, or it could
Only
be
gas. Yes, only gaseous distension. Yes.
only gaseous distension.
Yes. Okay, now we'll shift to expert opinion.
Want me to speak? So
Yes,
I'm
Lakshmi
quite
first.
happy with X-ray chest. It looks okay. It looks that big patch that was there, I can't see. So I'm happy with that, and I'm going to leave that stenotrophomonas aside and not let it bother me. Now the problem is the baby is still having a sensorium, which is not okay. And how many days is the meropenem added and this now?
Yes, just I will show.
What day did you add meropenem and what day did you do this CBC? We were on day 16, no, almost?
Yes.
14.
Day 14. Yeah, so day 14 and day how many of meropenem? 3 days of
3 days,
meropenem?
3 days, 3 days, 3 days.
Okay, so if you say 3 days of meropenem, it is decent enough time. At least 5 doses must have gone. That would have means for any antibiotic, I would want at least 5 doses to give its, look at its half-life and look at adequate drug levels to have reached into the blood.
Yes.
So with that, if it is not happening, then there is a possibility that though that sensitivity looked great, it's possible that we may have some CRE-like organism. Carbapenem resistant organism is possible. So whether we want to increase our meropenem duration, like make it into a longer infusion using the, like the pharmacokinetics of the drug is a thought which comes to mind. And also, if possible, maybe I would do a ventric tap at this point and see if there is some ventriculitis, which is also causing this problem.
Okay.
Those are my thoughts.
Okay, Abhijit.
Yes, sir. Meropenem, they have been given for 3 days, sir. If the dose is proper and at least the duration for which we are giving the IV infusion is proper, I have 2 thoughts. I would like to escalate the antibiotic support and maybe add another antibiotic which is susceptible. Second thing, I will like to see if there is some fungal infection because he has multiple bugs. And third thing, as madam has said, is there like a ventriculitis is happening? Basically, we are developing complications of meningitis or any other new system is being involved. Would like to screen for that.
Any investigation you want to ask for fungal infection, invasive fungal infection at this stage?
So, invasive fungal infection means there are 2 things. If he was never catheterized,
No.
so
No.
candida is maybe there because bloodstream candida. So which for which bacterial blood culture is good enough in 48 hours.
Till now, it has not shown anything.
It has not shown.
Yes.
Or we can do a pan fungal marker. Like
Yes. So what? Just 2
Beta-glucan,
questions. What
go
about
to
galactoman and all these 2 investigations about?
blood beta-glucan may
Yes.
act as a good
Yeah.
screening test
Yes.
if you want to spend money that ways. But I agree with Abhijit saying a blood culture is good to pick up a
Yes.
fungal culture. So talk to your lab and tell the lab that I'm thinking of
Now-
fungus. Can you keep it longer or can you use
Now, just
appropriate
one
media?
quick question to both of you.
Hmm.
Are these fungal markers like do they really help you when you need the help? Yes, very pinpoint answer from both of you.
In my leukemic and immunocompromised patients, yes, they definitely help. Especially galactomannan, if I have a respiratory which is not getting better, if I do a bronchoscopic galactomannan, I'm very happy with the results. These are the two places where I rely on it.
Routine other patients? Abhijit?
In
A
other
bit-
patients also, sir, to us recently they have been helpful. They have been helpful, but the only time is the turnaround time from from our
Yes, yes.
here is
That's why I asked the question.
yes.
But turnaround time is quite high till the time already some or other outcome has already happened to the patient.
Yes.
my TAT is quite good for this thing. So at least for maybe 2 days, I will get a report.
Yes, usually we also get within 14. So
Yeah.
vitals were stable on day 14. Some weak cry was there, dull activity. We stick to whatever things what we have. We are not escalated anything.
Can we do empiric fluconazole by now? Maybe I will do that.
Okay, let's see. So this is one way, yes, possibility of adding that thing.
Yeah.
So now see day 16, that means fifth day of meropenem now. Platelets are becoming better, but CRP is rising still. So how will you take this? Stable, vitals are stable, baby's tolerate some daily feeds. First from PGs, then from experts. We have not changed anything. Is it time to do something? Yes, please unmute yourself. For the real patients, what we had in when we are managing these patients.
Seeing that the vitals have now become stabilized and even the counts are becoming better. So at this point, we would like to continue the treatment and keep a check on the CRP. And if there is any slight clinical deterioration, then we can think.
CRP is deteriorating, increasing.
As we can add fungal. We didn't get the fungal report yet. We can add.
We repeatedly asking microbiology lab as expert, and you were asking, and their answer was specifically there is no fungal growth. Yes, expert.
I would treat the patient, not the report. So I'd wait.
Yes.
Abhijit.
Same, sir. Same. He's getting better. I would just continue the treatment which is being given.
Okay, let's see what happens to the patient. So day 17, 18, vital stable, BF tried, GC better, treatment was continued. Day 19, baby started accepting feeds. CRP started dropping now, platelets have increased, WBC is 12,200 now. Day 20, accepting oral feeds, breastfeeds were continued, baby shifted to the mother. And day 22, that was almost 14 days of meropenem. CRP came to 3, platelets normal, and patient we could able to discharge. So now question is, what comments first from PG students? So what things have gone wrong? What things have gone correct in this case? And how will you take this case? So what will be your final diagnosis in this patient? Unmute yourself. What things you learned from this case? And any other thought, any other deviation from our side you would have taken, you would have thought? Patient is better. Yes.
Label like give a diagnosis of a late onset sepsis.
Yes.
With, in a case of RSV positive
Bronchiolitis.
Yes. In an ICU graduate.
Experts, what was different in this case, and how will you can summarize this? Some things which are not fitting, some things are fitting. A message to the students. One will 2 points from each, then we'll discuss something about this case. First, Abhijit.
Yeah. So the learning points, many like that, a child with bronchiolitis, specifically if he's having apnea, a proper use of obviously RSV we suspect, but if we do a PCR, we get to confirm also. Second very important thing, in towards the end of the case, don't chase the parameters. Overall, see the patient, and I don't think any differently I would have done. Well managed case.
Yes, Lakshmi, anything you would have done differently?
No, sir, I don't think anything I would have done differently. The only thing is there were one or two organisms, Ctenotrophomonas we also get, but in this CSF, that organism which we got, somehow I heard it for the first time.
Okay. Lakshmi?
So what was
Till
different?
case till now, yes.
Different in this case was actually the initial part was pretty standard, where the child came as a respiratory infection, got, because he's a young one, he had he had worsening, and he had apneas, which is a common presentation. Probably that meningitis, where we just picked it up only on that MRI and the CSF culture. That is a little problematic in itself to accept, because there is some MRI evidence. Otherwise, it's difficult. The blood culture sepsis is pretty known in that age group because of their own poor immune status. And yeah, the other learning, there are two learnings here. The one was the Ctenotrophomonas, which we did not treat because we saw the respiratory pattern and the respiratory symptomatology got better. And the other thing which we did not treat was the rising CRP on day 17, 16, 18. That time when we were very tempted, when we were already at our wit's end. So those are the two things. So treat your patient and not your reports.
Then we went to the literature, and something we could able to get. This is from BMJ publication 2019. This is a systematic review of cases of meningitis in the absence of cerebrospinal fluid pleocytosis on lumbar puncture. This was 124 cases from 51 articles. Outcome of 86 cases, out of which 27 died, 59 survived. Mortal. And what they found is meningitis in the absence of pleocytosis on CSF is quite rare, which was in this case to us. It was quite challenging to diagnose and to treat. Fortunately, CSF culture has grown very different kind of organism and responded. This is the I want to go. This is the demographics of gender, pathogen, and comorbidity and outcome of these patients. So if you see the neonate, there are almost 17 cases, and you see the pediatric. Most of the pediatric population was there from 2 months to 15 years. And see that here see that this mortality was very low. That means only 16% was there. And organisms you find most of the times, almost 75% or 72%, it is a bacterial. So this kind of CSF pleocytosis negative meningitis really be because of fungal and viral. So very viral can be there. Most of the times we cannot able to isolate. It goes without saying that this is a very rare thing, and you have to take things of that means proper handling of the sample and what you call as a proper examination of the sample by expert pathologist immediately within 15 minutes is expected when you do the CSF. Coming to the Spingomonas possimorbis is a rare infectious agent found in the cerebral fluid. This was published in Korean Neurosurgery Journal 2017. Is a gram-negative bacilli. It has existed in the soil, drinking water, and plants. It has been isolated from drinking water tanks, respirator, and hemodialysis devices in the hospital setting. So we traced this also about our water resources, and unfortunately we could not able to get anything from any of our water sources. So we have to consider it as a thing from that means not related. This was not a hospital acquired meningitis. Third part was, which was interesting in this case, was this Stenotrophomonas maltophilia is actually a emerging ubiquitous pathogen So looking beyond, this is a very good article from Frontiers in Microbiology from 2017. And they said it's a commensal and emerging pathogen earlier noted as a broad spectrum life-threatening infections among vulnerable. But more recently now pathogen you can see this is an immunocompetent individual also. So it is very important that from where you grow, this is very, very, very important. If you grow from blood, that means these childs are very sick and they have almost very high mortality. But in this kind of, if you get it from bronchoalveolar lavage, especially from biofilms, and if you are, that's why I asked about PGs, how much colony count is there. If it is more than 10⁵, you have to take it significantly. Anything between 10⁵ to 10⁴, you have to take with pinch of salt, whether it is a really organism which is responsible for actual your disease process. With this, I end my presentation. So this was a very interesting case what we handled. There are 2-3 issues what initially as a consultant and as a counselor we faced in this case. Initially, organism which was responsible for the pneumonia was RSV we could able to detect. In initial, whatever episodes were occurring of apnea, whether those were contributory to the hypoxia or contributory to the underlying meningitis which was started at the beginning, was not an easy issue to settle. Over the period of time, we ventilated, patient developed myocarditis, which can be contributed to the RSV. Once we were in the phase of extubation, he has developed something new patch. Whether that patch was really contributing to the organism or it was really contributing to the RSV pathology itself, as Abhijit has pointed out, because of atelectasis and all that, that was a question. To label it as a VAP, it was very tricky because except for the new onset radiological changes, other things were not fitting in this case. And our ventilation things was 5 to 7 days. As far as we tried to investigate the apneas and seizures in a very systematic way and repeatedly, but we could not able to get any metabolic cause. We could not, CSF was normal twice. This was again an annoying feature. As a treating physician, you can understand. So there was nothing in your hand. Cranial USG was showing only dilated ventricles. When we reached to the MRI, then we could able to get some clues. And after we started getting cultures came in a very different way, that different 3 attacks from 3 different organisms to us. So wish to take seriously, wish to just, and last thing was when we started hitting the organisms properly with proper doses, still patient was deteriorating. And that was the question it was really challenging for us to give the answers for the patient's relatives, why in spite of that. But here the one message is that we could able to hold nerves. We will stick to the basic principle that, as Lakshmi and Abhijit said, we treat the patient and not the report. And finally, we could able to get the patient out from all these situations. And this is under publication. This is a very rare case of CSF negative pleocytosis with two different organisms, which are again rare. And this Sphingomonas recovering from CSF itself is a very rare thing. Quick comment from experts, and now it's time to say comments from mentor, and then we'll come to Bhavesh and Ram Gopal sir.
I just want to say that Sphingomonas we have seen occasionally in the ICU. I've seen it more in patients who have had multiple other things. So I know one SRSC patient who had probably Sphingomonas. That's the one I can remember just now. So patient was already having multiple MDR one at least MDR organism, which we were treating, and we found Sphingomonas also, but we found it in the bloodstream. That's all my experience. Maybe I have had 2 patients. The other one I can't remember just now what the patient was. Maybe it was a burns wala patient who had 60% burns. That's the one I can remember, but both had bloodstream infection is what I remember.
Abhijit, from concluding comment from you.
We have already spoken. So there are many learning points we had already enumerated, and it's a good case to manage.
Now coming to the PG students, they have nicely as far systematically they have approached this case. Yes, it was a difficult task to detect, diagnose different complications. It was a difficult task process. Lot of microbiology things were involved in this case, and you have I congratulate you and mentor both from BJ about this. It suggests a good training and systematic approach to deal with this kind of very difficult cases. Even in spite of almost 25 years of my critical care, we also face this kind of challenges. But in spite of that, your choice of looking towards diagnosis, looking at in a systematic way, approaching the patient, not missing the things was appreciable. And I congratulate Dr. Uday and your madam also about this very systematic training to the students. Now it's come to Dr. Uday for your comment before we conclude this remarks from Bhavesh sir and Ram.
Yeah,
And
thank
sir,
you
few
very
questions
much.
from the chat box.
Yes, we'll take, sir.
Thank you, sir. Thank you, Patki sir, very much for this interesting case. And I thanks expert also for their approaches. Just to add one comment, actually on day one, the child has come with recurrent episode of apnea. So I think we could have gone for the CSF on day one only. So that is just the additional point what I feel, because there is a history of apnea on the day one. So whether the meningitis was there right from the beginning, that we have to think, because the child is already having fever with some respiratory tract infection. So maybe in approach, we could have done one CSF right on the day one. That is the point I just wanted to highlight. Thank you very much for your interesting case, sir. Thank you.
Just I'm going through chat box. Majority of there are having they have put MMC numbers. Just let's see any questions are there.
So there is a question, if I may put it for
Yes.
you, sir. Yes.
Yes, this
So-
is yes.
Yes. So of course, this was a quite a tricky and a mind-boggling case where it was difficult to understand which is a deep fake and which is a real infection. So there is a question, sir, that is in that same hospital, are we getting the similar organisms in other babies as well?
No. This was only case in our whole hospital. So there's no organism. Yes, I think Bhavesh has asked this baby at high risk of fungal infection. Yes, this was I think during the discussion. Just let me see any other questions are there.
Yes. So there is another question, like, do we treat anemia also with such stormy course?
The two important principles are there in critical care. When once patient is hemodynamically stable, don't try to raise the hemoglobin above 7. So if it is hemodynamically unstable, means its oxygen requirements are high, then only. Otherwise, blood acts as an immunomodulator, and they are likely to develop complications. So if we unnecessarily treat this is called as a restrictive transfusion guidelines as per the new things are there. So this patient was never hemodynamically unstable. So we never given thought to treat that anemia.
Yes. And I think this question, sir, has discussed in detail that whether this was an hospital-acquired infection or not.
Yes. So this was not a hospital-acquired infection, definitely. This was because we could not, this was thing as, and the one tricky thing here was twice CSF was normal. Initially, as Uday has pointed out, but at that time I would not have, but the thing would not have shown because it was a classical acute RSV spike was there, of acute crisis spike was there. So that time, I don't know whether it would have helped, because after 3-4 days also CSF has not shown that thing. Any other questions are there?
Yes, sir. Yes, sir. So
Yes.
is there any role of biofires in such cases? Although we had shown one report.
Yes. Biofire we already sent, and it is a real new thing, because otherwise we would have had tangled between whether it was a primary viral infection or whether it was all community acquired, and something would have got very unfortunately from some other organism. Our case would have landed definitely to a different perspective, and we could not able to pinpoint this case. So definitely biofire is there, but as Lakshmi has already said, we try to do it as early when you do intubate, and try to take first samples not after 2-3 things are there when you are already done so many suctions. After 24 hours, biofilms are already formed. That time it is of no use. Yes, sterile films, sterile fluid like CSF definitely is helpful in getting the thing. So whenever you get a sterile thing like bronchial aspirate or sterile fluid, definitely gives a BioFire as value. And it was now majority of the cities like Mumbai and all that, most of the hospitals have their own. You can customize that also as per the need, as per the epidemic is concerned. So you can curtail the cost. And that cost, because we have IAP has come with 2 good modules. One is on by our own module like LEAP module, iLEAP module. We are dealing with how respiratory things are there. And other IAP has come out with the diagnostic stewardship module. In these 2 modules, these aspects of when to send, when not to send, not to, these are been fairly discussed. This is not the platform to discuss limitations and advantages of BioFire. But definitely in this kind of tricky situation, and I would like to add one point here, to me, one expert also will happy. When the child is much sick and we need to go towards pinpoint diagnosis, BioFire definitely helps rather than going for empirical therapy. You go for a definitive therapy. When the child is going like subacute or chronic courses, BioFires have not much role. Any other questions, Ripa?
Yes, the 2 more
Dr.
questions are there,
Patki,
sir.
I had a
Yes.
question.
Yes.
Yeah, so very nice case and very 3 different organisms, so challenging. Recently, we also had one Spingomonas, and I had not dealt with Spingomonas before. Thankfully, the infection was not very severe, and the baby went home. This was a neonate. My question was, we used mannitol here, I think, in this child.
Yes.
So, what is your experience with using mannitol in neonates and parents?
Yeah, I purposefully said when by presenting also that was only 1 dose I had given. At that time, I was suspected whether it's a race ICP and some kind of coning. Usually, it is very rare in that kind of age group. But usually, we don't give now 3% NS is a quite safe, quite controllable, and that's why we are not using mannitol routinely. Can be so 3% NS can be used in shock. We wish I think Lakshmi and Abhijit both will be agreeing that only in desperate situations where there is coning and your neurosurgeon is not arrived to do the craniotomy and all that. So either you do hyperventilate and simultaneously give 1 or 2 shots of mannitol. Otherwise, mannitol doesn't have much role nowadays in this.
Agreed.
Great.
So there is a question, a clinical question, that whether apnea can be a presenting feature of meningitis.
Yes, apnea was actually a convulsive apnea. It can be present because of any cause which leads to convulsion, can lead to convulsive apnea. That's why I mentioned that heart rate was 230 and that time child was hypoxemic, apnea. All this can be explainable. And I think Abhijit or Lakshmi both have pointed out pertussis can also lead to this kind of things. So, and the only thing was there was not a lymphocytic predominance was there. Pertussis get a very lymphocytes, 70-89% lymphocytes are there. And that comes and at that time, these apneas are usually followed by a post-tussive apneas, post-tussive vomiting and post-tussive apneas. That's how we could able to differentiate between this pertussis and other things. Yes, pertussis should be the organism considered for this kind of convulsions also. But these are usually post-hypoxic convulsions.
And so suppose if we have such a patient with polymicrobial infection, so do we investigate for the host factors? Do we also consider immunocompromised state?
Yes, till as far as CBC is concerned, and there was no leukopenia, there was no absolute lymphocytopenia. So these things, HIV status was okay. Patient had improved. We remember this meropenem was given for 6 weeks. You have to treat. I forgot this. We have to give whenever there is CS meningitis is there. You have to give for a very prolonged period. Osteomyelitis and meningitis. These are the 2 dreaded infections where you have to, even in spite of everything is normal, you have to give for a very prolonged period. Yes. Any questions? Any questions? So any specific faculty or experts are there?
No, nothing which I can see at present.
Bhavesh sir, your comment and then we'll go to Ram sir. Unmute yourself.
Pallavi, unmute Bhavish.
Yes, sir. Already done.
Yes.
Bhavesh,
Okay,
sir, try once. Yes.
yeah, now I'm able to. So first of all, excellent case as usual. The last webinar also you had excellent case, a lot of learning stuff, and couple of comments and maybe a couple of questions. So comment it would be something like if we analyze as a macro view, not a micro view. So as a clinician, when you're managing on a day-to-day basis for almost like 21, 22 days, you will be so engrossed into the whole management. If I understand this last 1 hour of a discussion as a macro view, so this neonate, which was a twins, little low birth weight to begin with, presented with the early respiratory infection and more than one system involvement at the beginning itself. So fever, which is a inflammatory marker, this child had a respiratory involvement, this child had a CNS involvement to begin with. And all this while the child grew almost 3 different organisms from 3 different sites, but never went into a septic shock. This child never went into a septic shock. I mean, this para-neonatal age group and a low birth weight, immunocompromised, partly immunocompromised state, they usually tend to get a lot of a septic shock, which never happened. So this is probably a viral infection to begin with. If you analyze the counts also in the initial phase were not very high. And also the inflammatory markers are not very high. Almost 40% of the RSV, the infection, proven RSV infection is known to have a co-infections with the other bacterial infection. And as usually, this child got a different site infection like brain. So this is one comment. Also, we had one child with the proven RSV infection, little older children. So this child had RSV proven, and after almost 5 to 7 days, he started having a paraplegia kind of a manifestation. So he could not walk, and he had some drowsiness. And when we worked up for this I'm talking about almost couple of years ago during the COVID time, he had a RSV encephalopathy, and the CSF we could prove that it was an RSV infection. So maybe whenever we have just such challenging case and we have a CSF which also can be analyzed for viral marker, viral PCR based assessment apart from the cultures. So this is one my comment. And couple of questions. What was happening to the other twins? Like this is second of the twins. During this whole process, was the first twin normal or that
Yes,
can
other twin also has RSV we could able to prove, but had very normal course. 4th day child baby went home, and both the babies we are following both have normal development. There are no further seizures, and there was no family member have been affected. Though mother and father had some mild URI.
Great, excellent case again. Thank you for enlightening us with these difficult cases.
Okay, thank you. Ram Gopal sir, your comment.
Excellent case. Only one question is, every time when you went to the parents and declared a new organism, what was their reaction? And
Yes.
it was very difficult probably to convince them.
Yes, definitely. It is very difficult, as I said, as always, by Lakshmi and Abhijit also will be agreeing with me. Is most of part of our ICU is more of a counseling, just learning and doing counseling and all that, and they're keeping the faith there till, because so many things we are getting, so many investigations we are ordering, shifting such a child for MRI from 1 floor to 5th floor with oxygen, you can understand, and 45 minutes in the MRI, it was a very adrenaline force, because any child, that child can arrest and you have nothing in the MRI room. That's why I was asking about both Lakshmi and Abhijit, whether CT or MRI. Because really, I personally went to this MRI and I was just hoping that this child should come out of MRI. Otherwise, MRI would itself been a big crash for that child, because hypothermia, the sound, so much handling lines, and it is very, very, very difficult. But thankfully, this MRI could able to pick us. CT would have done, we would have been landed in trouble. But CT would not have given us a thing. As you said, exactly, it is very difficult to counsel these parents because they don't know. In fact, many pediatricians also asked me when they taken this report to many pediatricians, and they also called me, sir, kya ho raha hai? What is this happening to this child? Because yes, this is a rare things just happens. And the whole aim of is not putting this in different organisms and all these things. So such things can happen. How your approach should be. This is the way. That is the basic aim of this kind of case live book presentations, with almost very good comments from expert like Abhijit.
Yes, sir. Thank you very much. Excellent case, like last time.
Thank you.
Till end, we were just listening the story, what is happening. Yes, Ripa.
Yes, sir. Yes. So, thank you, everybody. Especially, I thank our experts, Dr. Lakshmi Madam, Dr. Abhijit sir. I also thank our moderator, Dr. Patki sir, for so efficiently taking us through all the twists and turns of the cases. And our PGs, who I feel, they attempted everything so courageously, and they gave the approach also, whatever they were thinking. It's not easy, to do it so spontaneously. So I definitely congratulate them, and I thank them also for coming up here. And of course, I would like to thank their mentor, Dr. Uday Rajput sir, for training them so well. And I would also like to thank all the delegates, and of course Dr. Bhavesh Mithya sir. This is his brainchild, and this is helping so many of us to learn so many good points. So today we learned about this preterm NICU graduate who had RSV pneumonia, had a stormy course with the problems in ventilation, and then developed this MDR Klebsiella infection. Whenever there was a problem with whether what we have learned that we should never chase the labs. The key point that whenever there is no CSF pleocytosis, or even though there is culture positive, we have to take that with a pinch of salt, and we have to keep interpreting our reports by keeping the patient in mind. And with this, I would just like to end that always prevention is better than cure. If suppose if you would have the RSV vaccines, which we have in abroad, where they're even vaccinating the pregnant mothers, or doing the passive immunization with palivizumab or Beyfortus, probably this child would have not gone through so much. But thank you, everybody. Thank you, everyone, for joining in, and thank you. Thank you so much. Good night.
I think Aarti madam is there. She is HOD from BJ Medical College. Madam, can you give your quick comment?
Please, madam, please would you unmute yourself and give your comments?
Aarti madam. I think
Pallavi madam.
Ma'am, unmute permission is given already.
Okay.
Aarti ma'am is there.
Yeah, I had seen her. She was there.
Yes, yes, sir. She is there only. And unmute permission is also on.
Okay. Okay.
Madam is in Delhi today. I am not sure she'll be able to join.
Okay, Rajesh, then. Thank you.
Okay, so we would
can
end it
end
here.
up. Yes, Pallavi madam.